And with no further ado, I'll introduce Una McKeever from St Vincent's Hospital in Melbourne, who will be speaking on the three novel models of outreach integrated health services for vulnerable populations. Thanks, Una.
Clicker? Ah, the clicker, sorry. Okay, all good, thank you. And apologies in advance, I've got some paper notes due to technological issues, so I'll try and minimise the noise, and I'll probably use my full 15 minutes. So now the mouse. Yeah, doing that. Oh, okay. Wrong way. It's gone blank. Okay. So just for those who aren't local, I'm from St Vincent's Hospital, Melbourne. It's a large tertiary public teaching hospital. It's part of a parent organisation, St Vincent's Health Australia, and of note it is a mission-driven organisation, so is founded on values of service to vulnerable populations. I'm Una McKeever, the manager of the Health Independence Program, and again, for those who aren't local, Health Independence programs include things like our community rehab centres at multiple sites, several clinics that are outpatient based, including continence, memory, falls and balance, residential in-reach, some statewide services like a large pain service, polio services Victoria, and a complex adult disability service, and a large complex care service. At St Vincent's, that includes 3 streams of care: chronic disease, complex aged care, and a psychosocial team, and our psychosocial team is particularly large given the mission of St Vincent's and our location on the fringe of the CBD. We also have an additional service within that psychosocial stream, which is a residential cottage, a 6-bed step-up, step-down facility for people who are homeless or marginalised. Given that strong focus on serving vulnerable populations and aligned with what we know about the social determinants of health, people experiencing social disadvantage, including homelessness, substance use and mental health issues, experience poor health outcomes, high rates of chronic disease that are untreated, and shorter life expectancy. Many are not linked to mainstream primary health services and cannot prioritise their health needs over their daily survival. Getting a meal often usurps the need to go and get a blood test or to get treatment for a wound. Consequently, their health seeking is often delayed, and that leads to them having a high rate of ED presentations at a later stage in their illness. And that means that there are preventable outcomes that, if we're using assertive outreach and primary care, where we can make a difference. These 3 initiatives are all funded by the St Vincent's Health Australia Inclusive Health Fund. That's a significant investment by St Vincent's Health in funding new models of care, research and contributing to the evidence base, and also aiming to inform an advocacy agenda. There's 5 target groups within the Inclusive Health Fund, which are listed up there. And it really aims to generate some robust data that we can use to change structures and systems and influence policy. So with funding from that fund, we're piloting 3 novel models of integrated care outside traditional hospital walls, where we're taking the care to disadvantaged people where they are. These models broadly aim to establish partnerships with key community agencies to establish integrated and proactive health responses, to engage hard-to-reach consumers, to improve the health outcomes of vulnerable consumers, and to reduce preventable acute hospitalisations. Models 1 and 2 are 2 years into 3-year pilots, and the 3rd model has just commenced this year. So the first model is a primary health hub at the Salvation Army 614 precinct in Burke Street in the CBD. The 614 hub provides a very large gathering place for homeless people within the CBD. One of their key services they provide there is the Hamadava Cafe, and they provide hundreds of meals daily from that cafe. They also provide an overnight safe place for people to come and sleep, particularly so during winter, but they would often have between 80 and 120 people that stay there to stay off the streets. They also then provide other practical supports. So we've embedded 1 FTE of registered nurse and 0.5 of mental health clinician on site to engage with consumers to triage and assess and treat acute health needs, commonly things like wounds and infections, to address chronic health needs, and to link people into appropriate primary or tertiary health services. As part of the pilot, we've established a dedicated clinic room, and we've also developed very strong links to other services, and particularly the CoHealth Green Cross bus, which is a bus that delivers GP services around the CBD. Initially, we'd intended to embed a GP in our project, but rather than duplicate what was already there, we have established really close partnership with them, and that's working really well. The health conditions that are seen and the interventions that are provided are probably not surprising. The small vignette that's up there, though, to me is surprising, or at least I think it should be. And talking of a middle-aged man with a recent 4-foot amputation who approached the nurse for dressings. His wound was breaking down and was dressed only with table napkins. Fresh dressings were applied and regular follow-up was provided by the nurse, while we then made efforts to re-engage him with the surgery team that had performed the amputation. The case studies that we're seeing coming out of the work, even though it's still being evaluated, the qualitative outcomes and the case studies are really quite powerful. The other thing to note is that the development of trust and non-judgmental care delivery has been really critical. Second model is in partnership between St Vincent's, Jesuit Social Services, Bolton Clark and the University of Melbourne to embed a 0.8 registered nurse within Jesuit Social Services Reconnect prison release case management team. Nurse provides one-on-one clinical care to participants and secondary consultation and capacity building to the Reconnect team's 18 case managers. Prison often offers a period of health stability for people. People leaving custody have complex health needs and poor health literacy and a high prevalence of chronic illness, mental health and substance use. Within the first weeks of release, ex-prisoners are twice as likely to be hospitalised than the general population. There's growing evidence that better health is associated with reduced recidivism. Of note, the service that we've embedded the nurse with, the JSS Reconnect team, works only with high-risk offenders. We recognise that there are health needs for all people exiting prison, regardless of their risk category. We're seeking to contribute through this project to the development of a framework for broader post-prison release healthcare. We've outsourced the evaluation to Professor Stuart Kinner at the University of Melbourne, and the data linkage that we are intending to do has been laboriously slow due to the complexity of the ethics and the approval processes. We're optimistic of that starting later this year. This year's rapidly running out. And again, another case vignette from this team of a frail 82-year-old man released from prison. He had no friends or family and he required immediate placement in an aged care facility. The registered nurse facilitated an ACAS assessment, contacted multiple facilities until he was finally placed appropriately in a psychogeriatric facility. The nurse coordinated his care between a GP, a neurologist and the aged care facility to ensure continuity of care, medication management and implementation of behavioural management strategies. The nurse also supported the client through a range of medical and diagnostic appointments, and eventually a successful guardianship application was made. This is not an isolated case, and I know from the time when I used to work in our emergency department that we would frequently see people coming into emergency post-prison release who had no connection to health, to housing or to other services. The final model that I'll mention, which is relatively new, is a partnership between St Vincent's and the North Richmond Community Health Centre and their medically supervised injecting room, embedding an infectious diseases nurse and a mental health clinician to engage with consumers to address their complex physical health, mental health and substance use issues and psychosocial needs. The medically supervised injecting room is relatively new in Victoria. It only commenced in July 2018 and it's the only one we have in Victoria, and it is a trial site for 2 years. It's expanded from mid-2019 into a new purpose-built facility and has increased from 11 booths to 20 booths, and in its smaller form was seeing more than 200 people a day. We know that injecting drug users may have multiple other vulnerabilities, and so we've embedded this model to opportunistically connect with people using the service. From a partnership perspective, we're not just partnering between St Vincent's and North Richmond. We also realised in our fairly early stages of planning that we needed to partner significantly within St Vincent's. So we have senior representation from addiction medicine, our gastroenterology department, our psychiatry, emergency department, mission and the HIP program, along with the medically supervised injecting room and North Richmond GP group working together to deliver this service. That meant considerable consultation, needs analysis, model of care development, and it's been a significant investment to get it up and running. Of the conditions that are seen, bloodborne viruses certainly feature. Of note, clients using the service often come either as an alias or refuse to identify themselves, particularly initially when they're using the service. So interventions are often brief and opportunistic, though around 15% have been taken on and agreed to longer term care coordination around managing some of the psychosocial vulnerability. I've put up, I think, the basic numbers and the types of interventions again that we're delivering. The key link has really been with the gastro department at St Vincent's, and that's been around being able to engage in Hep C treatment for patients using the facility. So in terms of successes and learnings across the three models that we're in process of implementing, partnerships have been robust and have been a real success. There's also been really high rates of consumer engagement and satisfaction, and the evaluation is providing us with really rich information. In terms of learnings, the significant time required up front to develop the partnerships is something that we hadn't probably initially factored in. The necessity for steering groups across all partners to ensure robust clinical governance and operational governance requiring MOUs and quite lengthy ethics approvals, again because we're working with vulnerable populations. Staff safety has been a focus, and keeping staff embedded in the new service, but also maintaining their links back to their parent team at St Vincent's so that we have clinical oversight of how they're delivering care. Another area requiring upfront investment was the development of a rigorous evaluation methodology before we thought about doing anything. And the one that we haven't done so well with so far is the plan for sustainable funding, which currently remains outstanding. Whoop, one too many. Sorry. Across health, housing and welfare sectors, there's an increasing recognition of the need for integrated health and welfare services, and particularly in these models we've looked not just at integrating health but in integrating cross-sectorally. St V's is providing significant investment to pilot these models with comprehensive evaluation frameworks and to aim to add to the evidence base. Just in a positive note, the Salvation Army Primary Health Service is nominated for a Victorian Public Healthcare Award next week. I made it.
Well done.
Okay, do we have any questions? We have time for one or two questions. Go for it.
Thanks, this was a fantastic presentation and you, so positive, they're really great models. But I wonder, I come with a prevention lens, I guess. Has there been any thought or for how to embed prevention into the model? I mean, I know that working with very vulnerable cohorts who have not got a lot of space to deal with, and they're looking at having wounds to look at the word. But I'm just wondering if you've thought any about prevention.
Yeah, look, I think a great point and a great question. We are reasonably downstream with the groups that we're targeting, particularly in the medically supervised injecting room. We are strongly looking at how we can link people into ongoing support should they wish to engage in drug and alcohol services, and hence we have our addiction medicine team involved from the start. With the other services, these pilots are part of our bigger group of services, and so we do have well-established models that are in a more early stage intervention. I don't think we have enough focus in that area, and I think that's something that we probably need to look at more. But our remit is for people who have established illnesses, unfortunately. I think a more upstream approach would be very much worthy of investment, yeah.
Thank you, Una. We won't have any more time for questions for now. Unfortunately, if we have any spare time at the end, we'll come back.